afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on the health conditions attributable to smoking and alcohol by Public Health Unit in Ontario. My name is Erin Hoban, and I am a senior scientist in health promotion, chronic disease, and injury prevention at Public Health Ontario, and I use the pronouns she, her, hers. I have the pleasure of moderating today's session. To begin today's session, I would like to acknowledge and respect that the lands we are meeting on are the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. May we respect and honor the many connections, relationships, and life journeys of Indigenous peoples. May their wisdom always guide our own path forward with open hands, open hearts, and open minds for the mutual benefit and success of all in Ontario. As a public health researcher, my commitment this year is to learn more about the residential school system in Canada and collaborate with Indigenous communities to think critically about how to address the inequities in health outcomes, particularly the health inequities in substance-related harm due to systems in Canada affecting Indigenous communities. I will now mention a few housekeeping items. First, the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I do have a couple potential conflicts of interest that I would like to disclose, which include I am a member of the World Health Organization's Technical Advisory Group on Alcohol Warning Labels and have received grant funding from CIHR to support research examining alcohol harm and alcohol policies. It is now my absolute pleasure to introduce the speakers for today's presentation, Naomi Schwartz and Justin Thielman. Naomi is the lead for smoking cessation and an epidemiologist at Ontario Health, where she has worked for the past 10 years. She has worked on multiple projects related to chronic disease prevention and surveillance. Justin Thielman is an epidemiologist lead in health promotion, chronic disease, and injury prevention at Public Health Ontario, where he has also worked for the past 10 years. During this time, he has led a number of projects examining the determinants of chronic diseases. Now I'd like to pass it over to Naomi to start the presentation.
Thank you, Erin, and good afternoon, and thank you so much for this opportunity to present on a new report that was recently released. The burden of health conditions attributable to smoking and alcohol by Public Health Unit in Ontario was a collaboration between Ontario Health and Public Health Ontario, and it is a pleasure to present on this work with my colleague, Justin Thielman. Just a note that of our disclosure that none of the presenters at this session have received financial support or in-kind support from a commercial sponsor, and none of the presenters have potential conflicts of interest to declare. The learning objectives for today's session are to identify health conditions that are caused by smoking and alcohol consumption, to describe recent estimates of deaths, hospitalizations, and emergency department visits that are caused by smoking and alcohol use in Ontario, and to explain the types of health conditions that have the greatest number of harms due to smoking and alcohol consumption. So a little bit about the report. The report presents smoking and alcohol attributable deaths, hospitalizations, and emergency department visits for Ontario and by Public Health Unit. As mentioned, this was a collaboration between Public Health Ontario and Ontario Health. The report is available at the Public Health Ontario webpage, and there's also it's also available on the Ontario Health webpage. On the webpage, you will find links to the report, Appendix A, which has detailed estimates by Public Health Unit, supplementary tables, which can be downloaded as Excel files, which include all of the data that we included in the report, as well as some of the data stratified by sex. We also have a link to the technical appendix, which has details about the methodology we used for the report. Just a quick note that the report and Appendix A are also available in French. Okay, so a little bit of background about the report. This report builds on the 2019 Burden of Chronic Diseases in Ontario report by providing data at the public health unit level in addition to Ontario level data. The original report was a collaboration between Ontario Health and Public Health Ontario, and we expanded on this report because we heard from our stakeholders that there was a real gap and need for this data at the regional level. So one of the objectives of the report is for the data to be used at the local level for policy planning. The report also aligns with the Ontario Public Health Standards goal to reduce the burden of chronic diseases of public health importance and improve well-being. I would just like to take this opportunity to thank these individuals and groups who provided feedback through consultation or by reviewing the report. Just a note about sort of how this report relates to the COVID-19 pandemic. So we understand that there may have been changes to chronic disease risk factors that have changed the prevalence of them throughout the pandemic, as well as healthcare utilization patterns and health outcomes. However, we weren't able to examine the impact of COVID-19 on smoking and alcohol attributable harms because the data that we had available at the time of the analysis only went up to 2019. However, we recognize that this kind of analysis is important. So when the data does become available, future research is warranted on better understanding the impact of the COVID-19 pandemic on chronic disease prevention and health outcomes. So a little bit about the approach that we took. So when calculating attributable harms, we're estimating the proportion of an outcome, for example, deaths, that are caused by either smoking or alcohol consumption. So really it's an estimate of the number of health outcomes that could be prevented if people didn't smoke or consume alcohol. So attributable harms were calculated for each outcome using prevalence of smoking or drinking, the relative risk for each disease, and the total number of outcomes in each geographic region, so in each public health unit. The harms that we included in the report were cancers, cardiovascular diseases, lower respiratory diseases, and diabetes for both alcohol and and smoking. And for alcohol only, we looked at neuropsychiatric conditions, digestive disorders, and injuries. The relative risks that we used for the report came from the literature and were used to examine the relationship between the exposure and the outcome of interest. Okay. So now I'm going to go into a little bit more details about the calculations that we did for smoking and present some of the results. So now I'm going to go on to discuss some of the data that we reported on in the report, in addition to the smoking attributable outcomes. So we looked at the prevalence of smoking, and we used data from the Canadian Community Health Survey, and we used cycles 2015 to 2017. And what we found was during this time period, 17.5% of people in Ontario, age 20 and older, reported that they currently smoke cigarettes every day or occasionally. The data ranged between the public health units from a low of 12.3% to a high of 28%. We used the age cutoff of 20 and older because that is aligned with some of the other reporting standards and guidelines. For example, the Association of Public Health Epidemiologists of Ontario, so PHO, uses these guidelines. Public Health Ontario snapshots and Ontario Health's cancer profiles. Okay, so in terms of how we calculated the smoking attributable harms, so they were calculated using Levin's formula for each outcome and disease site using age and sex specific estimates. So the prevalence of smoking, we used current and former smoking, and that came from the Canadian Community Health Survey. And again, we used cycles 2015 to 2017 because those were the most recent data that we had available at the time of the analysis. The disease-specific relative risk, so current versus never smoking and former versus never smoking, came from the Surgeon General's report of 2014. And then the total number of each health outcome. So we looked at deaths, which came from vital statistics from the Ontario Registrar General's Office, and we had data from 2014 to 2018 available at the time of the analysis. The hospitalizations came from the discharge abstract database, and we had data from 2015 to 2019 that we used. And the emergency department visits came from the National Ambulatory, the National NACRS care reporting system. And that data came from 2015 to 2019. So using those inputs, we are able to calculate the provincial smoking attributable fractions. From there, the PHO estimates were calculated by multiplying provincial age and sex specific smoking population attributable fractions by the total number of outcomes in each age and sex group for each public health unit. Okay, now we'll get into some of the results. So in an average year, an estimated 16,673 deaths, which represents 17% of all deaths, 68,046 hospitalizations, which represents 8.7% of all hospitalizations, and 125,384 emergency department visits, which represents 3.4% of emergency department visits, were attributable to smoking in people age 35 and older. We used age 35 and older as our cutoff because this was the age cutoff used for the relative risks that were provided to us in the Surgeon General's report. As well, we recognize that there is a lag between exposure and outcome, which can be up to 20 years. And also recognizing that these outcomes for these health conditions are relatively rare in younger populations. Okay, now to get into the breakdown of each of the health outcomes by the disease categories. So you can see circled in red the disease categories that contributed the greatest number to that to the smoking attributable health outcome. So for deaths, it was cancer. For hospitalizations, it was cardiovascular diseases. And for emergency department visits, it was respiratory conditions. So this data is also provided to us, is also available, broken down by sex in the supplementary tables. But all three deaths, hospitalizations, and emergency department visits were higher in males than females for each of the disease categories and health outcomes. Okay, so we'd now like to just show you an example of what the PHO level results look like in Appendix A. So as mentioned, they are available from the webpage. You can access them and download them as Appendix A. And this is just an example of what one of the public health unit specific estimates looks like. So we've chosen Algoma. And again, we have it broken down for each of the disease categories. And just a note that we've also provided brief discussion of policies and programs that and opportunities to reduce health smoking. We've provided them at the federal, provincial, and local levels, and provided links to specific PHO opportunities to reduce smoking in your region. Policies and programs are all evidence-based that we've recommended and come from the Smoke-Free Ontario Scientific Advisory Committee. And some of the examples include increased prices and taxation, product and packaging restrictions, availability restrictions, frequent mass media health promotion campaigns of sufficient duration, broadened protection from secondhand smoke exposures in outdoor settings, homes, and workplaces, and increased access to smoking cessation programs. And I will now pass it off to Justin to discuss the alcohol methodology and indicators.
So the next few slides, we will talk about the prevalence of alcohol consumption in Ontario. And so these prevalence estimates are based on the 2015 to 2017 Canadian Community Health Surveys, which, as for smoking, were the most recent data that we had at the time of writing the report. And during this time, 33.2% of people in Ontario aged 19 and older reported having more than 2 drinks in the past week. So we chose 19 as the age cutoff to align with the low-risk drinking guidelines, which have now been updated to Canada's new guidance on alcohol and health that just came out in January. And then looking across Ontario's 34 public health units, there was a range from 23.5% in the health unit with the lowest prevalence exceeding 2 drinks per week up to 42.6% in the health unit that had the highest prevalence of people exceeding 2 drinks per week. And it's important to note that these estimates come from self-reported survey data, and people tend to underreport the amount of alcohol they consume by a pretty fair amount in these surveys. As well, people who tend to drink more, may be less likely to even respond to these surveys in the first place. So these are likely underestimates of the true prevalence of people exceeding 2 drinks per week in Ontario. And we chose this 2 drink per week cut point based on the low risk category of Canada's new guidance on alcohol and health. And so this new guidance that just came out presents risk from alcohol consumption as a spectrum of increasing risk. So the more you drink, the higher your risk. It also includes categories such as no risk, which is 0 drinks, low risk, which would be up to 2 drinks, moderate risk, which would be 3 to 6 drinks, and then high and increasingly high risk after 6 drinks. And we chose the low risk threshold for this particular statistic. And here we're looking at current drinking. So during that same 2015 to 2017 period, 76.8% of people in Ontario aged 15 and older reported current drinking, which is defined as having 1 or more drinks in the past 12 months. And here the age cutoff is different. It's 15, which aligns with data put out by the World Health Organization, the Global Burden of Disease Study, and other sources. And then across the 34 health units, current drinking prevalence ranged from a low of 63.2 to a high of 83.3 in the health unit with the highest prevalence. And then here we have binge drinking, or also called heavy drinking. During that same 2015 to 2017 period, 18.9% of people in Ontario aged 15 and older reported binge or heavy drinking, and that's defined as having 5 or more drinks in one sitting for males, or 4 or more drinks in one sitting for females, at least once a month over the past 12 months. And the prevalence of binge drinking in public health units ranged from a low of 13.3% up to a high of 28.4%. Okay, now we'll talk about the population attributable fractions for alcohol. And so the alcohol population attributable fractions for the harms we looked at, and the harms were mortality, hospitalizations, and emergency department visits, were calculated using an online tool called the International Model of Alcohol Harms and Policies, or INTERMAP for short. INTERMAP is an open access alcohol harms estimator that was developed by the Canadian Institute for Substance Use Research at the University of Victoria. So this tool is, anyone can access it online. It required us to upload specific data formatted a certain way, and then it calculated the population attributable fractions for alcohol for us. So we needed consumption data and harms data, so deaths, hospitalizations, ED visits, for the regions we were interested in 6 age and sex subgroups. So in each subgroup, we needed the prevalence of current drinking, prevalence of former drinking, prevalence of lifetime abstinence, and prevalence of binge drinking. We also needed average number of alcoholic drinks per week. So all of these data came from the 2015 to 2017 Canadian Community Health Survey. We also needed per capita alcohol consumption. And these data came from sales data from Statistics Canada, as well as tourist consumption and unrecorded consumption from the World Health Organization. And so the sales data and this consumption data avoids the underreporting that is common in survey data. We also needed to upload the age and sex specific number of deaths, which we got from Vital Statistics, hospitalizations, which was from the Discharge Abstract Database, and the Ontario Mental Health Reporting System, as well as emergency department visits, which came from the National Ambulatory Care Reporting System. And so within each of these age-sex subgroups, we needed data on 44 different health conditions that were previously determined to be either fully attributable to alcohol or partially attributable to alcohol. And these 44 conditions were specified by INTERMAP and based on previous research. And all of these data on alcohol consumption and attributable harms were loaded into INTERMAPs. And then built into INTERMAPs were relative risk estimates and relative risk functions. So like a dose response, a relative risk function, estimating the relationship between alcohol and each of the outcomes. And these risk estimates estimated the risk of harm at various levels of drinking. And so there were formulas on the back end of INTERMAP that use these relative risks, use the data that we uploaded to calculate the population attributable fractions based on the consumption patterns and harms in each subgroup in each region. Okay, and then INTERMAP gave us the population attributable fractions for each region and for each age and sex subgroup. So for example, if the population attributable fraction was 0.25 for colorectal cancer in males age 65 plus, that means in that subgroup, 25% of colorectal cancer is attributable to alcohol. And it would be a different percentage in different subgroups. So among females age 15 to 34, there would be a different population attributable fraction for colorectal cancer. And colorectal cancer is an example of a health outcome that is partially attributable to alcohol. There were also outcomes that were fully attributable to alcohol. So for example, alcohol-induced pancreatitis is fully attributable. That's right there in the name. It's by definition attributable to alcohol. So because it's 100% attributable, the population attributable fraction is 1. And that's true in every age and sex subgroup. So you've got each of the age and sex subgroups, each with 44 different health conditions that all have their own population attributable fraction estimate. And then in each of these groups, we had the actual number of harms, so actual number of deaths, hospitalizations, or emergency department visits, and multiplied those by the population attributable fraction in each group to get the total number of alcohol attributable harms in each of these groups. And then these 44 health conditions were summed up into 9 broader health condition categories. And we'll take a look at those on the next slide. And they were summed up further into the totals you see here. So here we see in Ontario, in an average year during the 5-year time span we looked at, there were 4,330 deaths among the population age 15 and older. This represented 4.3% of all deaths among Ontarians 15 and older. There were also 22,000 hospitalizations, representing 2.1% of all hospitalizations, and then almost 200,000 emergency department visits, representing around 3.5% of all emergency department. And so here, looking at the first row, of those 4,330 deaths attributable to alcohol, 1,204 of those were cancer deaths. And looking across the row, cancer deaths are responsible for the greatest burden of deaths out of the 9 different categories. And so cancer deaths are largely different cancers at different points along your gastrointestinal tract. So like mouth, throat, esophagus, liver, pancreas, especially colon. But then there's also breast cancer, which is a pretty large proportion of the cancers were breast cancers. And then we also see that in an average year in Ontario, there were 934 cardiovascular disease deaths, 126 communicable disease deaths. These were, the majority of these were lower respiratory infections for alcohol. 865 digestive disease deaths. So this would be like liver cirrhosis, pancreatitis. And then negative 67 in the endocrine diseases category. So a negative number represents a protective effect. So based on the relative risk estimates that we used, the estimates that were built into Intermap, low levels of alcohol consumption were protective of endocrine disorders, which is almost entirely diabetes here among certain population groups, and that's reflected in the negative number here. And then there were 329 neuropsychiatric deaths. The neuropsychiatric category includes a pretty wide range of conditions such as alcohol psychosis, alcohol dependence, epilepsy. There were 306 intentional injuries, 87 motor vehicle collisions, deaths, and 546 unintentional injury deaths. Okay, so I just want to also mention that we're going to come back to discussing these apparent protective effects when we talk about the limitations toward the end of the presentation. And looking at the hospitalizations, you see a different pattern from what we see with deaths. So here, it's the neuropsychiatric conditions category that has the largest number of hospitalizations attributable to alcohol, followed by unintentional injuries. And then looking at ED visits, it's the unintentional injuries category that by far represents the highest burden of alcohol attributable injuries, or alcohol attributable emergency department visits. And then as for smoking, we have these numbers broken down by sex in the supplementary tables that are available. I think there's a link in the report, and then there's a link on both the Ontario Health and Public Health Ontario website. Okay, but I can also summarize the analysis by sex by saying that for every type of harm, the harms were greater among males than they were among females, as they were for smoking. Okay, now here we have similar data for algoma. So this is to show an example of one of the 34 health units for which we have health unit specific data. So these are all in Appendix A, which can also be downloaded from the webpage. And then here, the numbers are much smaller because the population of Algoma is much smaller than the population across all of Ontario. But you can see a kind of a similar proportion of all deaths are made up by alcohol attributable deaths. And then here's the 9 different categories for Algoma. So here I think we see roughly similar patterns: highest number of deaths in cardiovascular illnesses, hospitalization, the highest numbers neuropsychiatric, emergency department visits, it's unintentional injuries. We didn't see the same pattern across all health units. So this again kind of shows why it's important to look at it at a more regional level. All right, and now we'll talk a little bit about something that was covered in the report. There was a brief discussion of policies and programs that could be used to reduce alcohol consumption, in addition to those that could be used to reduce smoking. And so these include opportunities for reducing consumption at various levels of government. So federal, provincial, and there were many examples of municipal level policies and programs that have targeted smoking and alcohol. And there are links to specific resources in the report that public health units may find useful. Now, this table is not in the report, but we wanted to show it just to show a comparison to help understand the scale of the burden from smoking and alcohol. So we know that COVID has caused a great deal of harm over the past 3 years. You can see here that from January 2020 to January 2023, COVID-19 caused 15,786 deaths, 64,740 hospitalizations. So extrapolating our annual data for smoking and alcohol to 3 years, we see that smoking caused an estimated 50,000 deaths and an estimated just over 200,000 hospitalizations, while alcohol consumption caused an estimated almost 13,000 deaths and estimated 66,000 hospitalizations in a 3-year time period. And so this isn't to minimize the impact of COVID. We want to show this comparison to flag that smoking and alcohol harms should be a priority area and an opportunity to reduce a pretty big health burden as we move into the post-COVID recovery. And we don't have emergency department visits included here because we didn't have those data for COVID. So I'm just going to summarize with some key take-home messages. One is that smoking and alcohol consumption are responsible for a considerable burden on the health of Ontarians and on the healthcare system as well. And this large burden warrants policies and programs at all various levels of government to try to prevent and reduce smoking and alcohol consumption. And as Naomi mentioned earlier, at the time of the analysis, we only had consumption data up to 2017 and health outcome data up to 2019. So we weren't able to look at the impact of COVID-19, but a future analysis could, and that would be an important area for future research. And I also want to mention some of the limitations in our methodology. So one is that due to small sample sizes, when we split the population sample up into the different PHUs, and then within those, the PHU, sorry, when I say PHUs, I mean public health units. And then within the public health units, split into the 6 age and sex subgroups, we found that our population sample sizes within each of those groups was not large enough to produce reliable estimates of consumption for smoking and alcohol. And so we had to use province-wide consumption data when calculating the population attributable fractions. We were still able to use public health unit specific harms data on deaths, hospitalizations, and emergency department visits. Another point is that I mentioned this earlier, but there are biases associated with self-reported data, such as recall bias, social desirability bias, and so on. Another is that for all of the harms except for injuries, we used the primary cause of death or the most responsible diagnosis to ensure that we weren't double counting deaths or visits. So if a smoking or alcohol attributable diagnosis appeared as, say, a secondary diagnosis or external cause code, it wasn't counted. And that's with the exception of injuries, where we did look at more than just the main diagnosis. As well, our estimates are based on the relative risks built into the Intermap tool for alcohol. But I do want to point out that in certain areas, in particular, the relationship between alcohol and cardiovascular disease, the literature is continuing to evolve. And so a number of older studies showed those protective effects between alcohol and certain cardiovascular diseases, ischemic heart disease and ischemic stroke in particular. But more recent literature has actually called those apparent protective effects into question, and those were not incorporated into our estimates. So if we had used these relative risk estimates that did not show the cardioprotective effects, the harms would have been a lot larger. And that's because there are so many deaths, so many hospitalizations due to ischemic heart disease and ischemic stroke. Another limitation is that the list of smoking and alcohol attributable harms in the report is not exhaustive. Certain outcomes, such as fetal alcohol spectrum disorder, had less readily available data and are not included. And we're only looking at harms that resulted in death, hospitalization, or ED visit. So different kinds of harms are not included. And then a last point is that smoking and drinking together, so if an individual smokes and drinks, the harms are greater than if you added the individual harms of smoking and the individual harm of drinking together. And so we call this synergistic harms, and the report does not quantify these synergistic harms. So again, the result is that the total harms is actually likely to be higher than what is estimated here. And then before we wrap up, we just wanted to talk a little bit about how this report can be mobilized. So we hope these estimates provide the impetus for policy and programmatic decisions around smoking and alcohol. We think the health unit specific estimates will be helpful for local level policies and programs. The estimates can also be used to draw attention to and compare the burden of different risk factors, including the burden on health and the burden on the healthcare system. Okay, I think now we're going to turn it back over to Erin for some Q&A.
Well, thank you, Naomi and Justin, for this impressive report and presentation. We will now move to the Q&A pod to address some of the questions. Please continue to enter your questions into the pod if you have not already had an opportunity to do so. I'm going to start with the first question. Justin, one of the audience members is asking, what is the date of the survey of drinking behavior, and does it capture the upward trend from the pandemic?
Hi, thank you. So the date of the survey of drinking behavior, the dates were 2017 to 2019. It was from the Canadian Community Health Survey. So no, it does not capture the upward trend from the pandemic. Yeah, that was the most recent data available when we did the analysis. I believe now up to the 2020 Canadian Community Health Survey has been released. Just very recently came out, but yeah, our analysis was the survey data was only up to 2017.
Thank you. Naomi, this question is for you. Are the health outcomes attributable to smoking based on smokers themselves, or does it also include exposure to ETS?
That's a great question. Thank you. Unfortunately, it only includes people who are current smokers or former smokers. We weren't able to account for those that have been exposed to secondhand smoke.
Thank you. Just flipping back and forth between alcohol and tobacco. The next question is an alcohol-related question, Justin. This person is interested to hear more about the statement that people who drink more are less likely to participate in the Canadian Community Health Survey. Is this based on socio-demographic factors associated with high levels of alcohol consumption?
I'll first start by saying that we did not look at this specifically in this analysis or in this report, but from what I've read, yes. So it's based on socio-demographic, exactly that, socio-demographic factors associated with high levels of alcohol consumption, and then I think individuals who may be experiencing alcohol dependence may be less likely to respond to these types of health surveys.
Thank you. Naomi, if you could please respond to the question, are there standard corrections available for smoking prevalence data similar to the alcohol consumption adjustments?
That's a great question. As of now, and as far as I know, there aren't. I think more people are maybe aware of how much they smoke, as opposed to, I think that there's less awareness and more education needed as to quantities of drinking and the harms associated with them. So I think that's where more people might underreport drinking, as opposed to people being more aware of their smoking status, whether it's current or former. And the questions in the CCHS are quite specific about what a current smoker and a former smoker would mean. So that's a great question. If anyone knows of anything, any other correction factors that might be needed to account for underreporting, then I would welcome that information. But as far as I know, there aren't.
Thank you. Justin, could you please give some examples of unintentional injuries for alcohol?
Sure. So examples of unintentional injuries would be unintentional poisoning by alcohol, unintentional poisoning by other substances, falls, and then smaller numbers would be things like drownings, fires, etc. I think the highest were falls and unintentional poisoning by alcohol.
Thank you. This is a question for either of you. Are there any plans for more analysis by health unit region?
For more analysis, but what are there specific types of analysis you had in mind?
That wasn't listed. I guess they're just wondering if there are any plans to do perhaps future analyses by public health unit.
Nothing I'm specifically aware of, but that doesn't mean that there aren't. There could just be that I'm unaware.
Yeah, maybe I'll just comment that I think the feedback that we've received from stakeholders, particularly public health units, are that local level data is really important for some of the reasons that Justin mentioned, that I think that sometimes the trends at the provincial level are not the same as at the local levels. So I think that's something we're definitely hearing and something we consider, at least at Ontario Health, for future reports or knowledge products.
Thank you. That is definitely a unique aspect of this report and very useful for the public health unit practitioners. So thank you for that. An alcohol question. Can you comment on the liberalization of alcohol policies over the past couple of years and what the potential impact that this can have on harms in future reports?
So I can't really comment on what impact that might have. That's not something that we looked at specifically in this report. We did include a policy section that looked at how certain policies have worked. One of them that I can recall is that restricting the availability of alcohol leads to lower alcohol consumption, and so that could be like restricting the time it's available for purchase, having fewer locations where it's available to purchase. So yeah, I can say that has previously been found to lower alcohol consumption, but I don't know that I can predict what future impacts would happen.
Thank you. Naomi, do you also show the rates of deaths, et cetera, attributable to smoking and alcohol by public health unit in addition to the numbers?
Yes, so for each health condition, we've provided the percent that's attributable to each of the risk factors. And that's available in the supplementary tables that you can access from both the Public Health Ontario and Ontario Health web pages.
Thank you. One person is asking if it would be possible to show the opioid 3-year comparison as well as the COVID comparison that you showed in the slide presentation.
Yeah, I don't have the opioid numbers at my fingertips right now, but there is the opioid tool. If you search like Public Health Ontario opioid tool, I believe that shows you the number of opioid related deaths, and I think also hospitalizations. And I don't know if you can, I'm assuming you can choose the time period that you want to look at, so you could probably get a comparison there.
Justin, another question for you. What do you think are the reasons why alcohol seemed to have a protective effect on emergency department visits?
I think the person asking the question may be referring to hospitalizations. We saw for cardiovascular diseases that there was a protective effect on hospitalizations, but not emergency department visits. And so the reason for that is the types of conditions people are being hospitalized for versus the types of conditions people go to the emergency room or to the emergency department for. So cardiovascular diseases includes ischemic heart disease, ischemic stroke, hypertension, and then atrial fibrillation, a few other things. And so out of all of the cardiovascular conditions, the protective effects in the estimates that we used were found for ischemic heart disease and ischemic stroke. And so those were more common among the hospitalizations, but then other conditions like hypertension, which had no protective effect at any level of drinking, were more common among the ER visits. So more people were going to the ER with hypertension than for ischemic heart disease and ischemic stroke compared to hospitalizations, where it was more common to have ischemic heart disease or ischemic stroke, which at low levels of drinking, the estimates that we used saw protective effect. I hope that answers the question.
I think you nailed it. Yes, I think that was the question. This question is for both of you. Have you noted any broad geographic differences in smoking or alcohol attributable emergency department visits, hospitalizations, or deaths? So looking at the data across the public health units, have you noticed any differences in smoking, Naomi? In the smoking outcomes, the 3 outcomes that you looked at?
That's a good question. I would say that there are probably slight differences, and that's really accounted for by different population sizes. And so some of that, is probably related to smaller samples provide slightly less reliable estimates. So it's hard to know whether those are true differences or the outcome of having small samples. I would say that for smoking, probably more so than For alcohol, I think the results were pretty similar and patterns were quite similar between health units. I know that there is a big difference in some of the prevalence estimates, but again, sometimes you know, when you put everything through the algorithm, you know, the one thing might cancel out the other. So it's hard to know, but we did see some variation. And but I think overall for smoking, the patterns were quite similar, even if the absolute numbers were slightly different.
Thank you. And Justin, could you comment on potential regional differences in either the prevalence of alcohol use or the alcohol outcomes that you were looking at?
Sure. I think it was a similar situation for alcohol where the totals didn't seem to differ dramatically between different health units. But the breakdown into the 9 different categories did differ somewhat. So for example, in Northwestern, there was a bit of a different pattern, and I can't recall off the top of my head exactly what it was, but I remember I mentioned that for hospitalizations, it was neuropsychiatric that was the highest, and then followed by, I think, unintentional injuries. That was for Ontario. And I think in Northwestern, it was a slightly different pattern. Something else was the highest, and I can't recall what at the moment, but that's all available in Appendix A on the report. So it was more, as for smoking, it was more the composition of the different types of illnesses that seemed to differ across health units for alcohol, rather than there were small differences in the overall harms. But yeah, where it stood out to me was in the breakdown between the 9 different categories.
Thank you. And just the last question before we wrap up, Naomi, was the analysis specific to cigarette smoking, or did it account for e-cigarette use?
It only accounted for cigarette smoking, although that is something that, you know, is really emerging in the literature, and you know, just getting more data on the prevalence of e-smoking or e-cigarettes. So definitely something that we'd be interested in potentially looking at in the future.
Wonderful. As we wrap up today's round session, I would like to give a big thank you to Justin and Naomi for presenting. I would also like to thank everyone who joined us for today's session. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you very much for attending, and have a wonderful day.